Hi guys, welcome back to my channel obgyn Made Easy. Today I'll be discussing antepartum hemorrhage. I'll focus more on placenta previa in this video, one of the causes of antepartum hemorrhage. In the next video I'll discuss on abruptio placenta. So what is antepartum hemorrhage? Antepartum hemorrhage is bleeding from or into the genital tract from the age of viability but before the birth of a baby. Age of viability in developing countries is 28 weeks, but for developed countries they use 24 weeks. WHO recommended age of viability as 24 weeks gestational age. So before it gets confusing, let's look at the basic anatomy of the uterus. This is your fallopian tube. This is the isthmus. This is the ampulla of the fallopian tube. Here you have the infundibulum of the fallopian tube. Here you have your fimbrial end of the fallopian tube. This is the ovary, and this is the round ligament. Okay. This is the uterine cavity, which is made up of the fundus of the uterus. This is the fundus of the uterus. This area here is the fundus. And this area here is the body of the uterus. Now there's a small portion here just above the cervix here. It's about 1 centimeter in the non-pregnant state. It's called the isthmus of the uterus. Now this area here is the cervix. Okay. Now this is the internal os of the cervix. This is the external cervix, the one you are able to visualize outside. Okay. And here you have your vaginal canal. Now layers of the muscles of the uterus are this inner lining here goes all the way here, is called the endometrium of the uterus. It's a thin layer. This muscle bulk here, the middle layer is the myometrium. And you have an outer layer here, which is known as the perimetrium. Causes of antepartum hemorrhage. 70% of the cases are placental in origin, being abruptio placenta and placenta previa. So what happens in placental abruptio is that there's a well-implanted placenta here, but there's premature separation of the placenta from the endometrium, which causes bleeding. Placental abruption is also known as accidental hemorrhage or premature separation of the placenta. And then you can have a placenta previa, a low-lying placenta that implants in the lower segment here. So the thing is, the uterus is divided into two sections, okay? There's the upper segment and the lower segment. The upper segment is thicker. This is the upper segment, whilst the lower segment is thinner. This is because the myometrial tissue is thicker in the upper segment and thinner in the lower segment here. So in placenta previa, the placenta is low-lying, meaning it lies in the lower segment. 5% of the cases are non-placental in origin, including vasa previa, uterine rupture, local causes like a cervical polyp, cancer of the cervix, cervicitis, local trauma, or a bleeding varicose vein. So what happens in vasa previa is you have a fetus here, and there's fetal blood vessels that are abnormally running across the internal os or just above the internal os. In uterine rupture, you have a uterine rupture. And local causes is where you have, let's say, a cervical polyp that causes bleeding. It may prolapse into the vagina or may not. So this causes bleeding. And you have cancer of the cervix. Now remember, in cancer of the cervix, you can have cervical erosions here, which may cause bleeding. Cervicitis is inflammation of the cervix, commonly caused by STIs, like sexually transmitted infections like chlamydia or gonorrhea or herpes simplex. So these cause erosions to some degree, which can cause bleeding, or just lesions which can cause bleeding from the cervix. And then you can have a cervical varicose vein, a bleeding cervical varicose vein. It's very rare though. And then you can have local trauma. Local trauma is in situations, let's say the patient took a fall or was involved in a road traffic accident which affected the gravid uterus, or gender-based violence. Or you can have local trauma also on the cervix. There's some cases where you don't know the cause of antepartum hemorrhage. You've investigated, you find the placenta is well implanted, there's no abruptio placenta, and you do a speculum examination, there's no any cervical lesions. This is unexplained antepartum hemorrhage, where you don't know the cause of antepartum hemorrhage, and it constitutes about 25% cases of antepartum hemorrhage. Placenta previa. Placenta previa is one of the causes of antepartum hemorrhage. It is a placenta that is implanted partially or entirely in the lower uterine segment. The key to understanding placenta previa is understanding the lower uterine segment. In the previous section, I said the uterus is divided into two sections, the upper segment and the lower segment. Now, what defines the upper segment and the lower uterine segment is the isthmus. Remember, in the previous section, I said the isthmus is about 1 centimeter in a non-pregnant state. When a woman is not pregnant, this small portion here, the isthmus, is 1 centimeter. So when a woman is pregnant, after 12 weeks gestation age, this small portion, the isthmus, starts to stretch. It continues to stretch until 38 weeks gestation age or even 40 weeks gestation age. So it stretches downwards to form the lower uterine segment. So the lower uterine segment is developed from the isthmus. Okay. So if a placenta is situated in the lower uterine segment at, let's say, 12 weeks gestation age, it's not yet a placenta previa, because as the weeks go by, at 28 weeks gestation age, 30 weeks gestation age, this lower uterine segment, it's still developing, it's still stretching. So the placenta might migrate to normally situate itself in the fundus. Okay, but in some cases it will remain in the lower uterine segment. It might still be implanted in the lower uterine segment here. That is why it is wise to repeat the ultrasound scan at 32 weeks gestation age, 36 weeks gestation age, and even at term to see if the placenta is still low lying. Because by then the lower uterine segment would have fully formed. The lower uterine segment is about 7 to 10 centimeters at term. This is in the non-pregnant state. The lower uterine segment has not yet formed. Okay, this is at 20 weeks gestation age. You have your placenta lying low here, but the lower uterine segment has not yet fully developed. Here at 32 weeks gestation age, you can say that the lower uterine segment has fully developed and the placenta is normally situated here. It has moved upwards. As the lower uterine segment stretches down here, the placenta is stretched upwards here, which normally gets situated in the fundus here. Now, in cases where the lower uterine segment has fully formed here, but the placenta is still low-lying, this is what you now call placenta previa. Okay, so what happens is that the fetus exerts some pressure on the placenta, and even when the lower uterine segment is stretching, as it stretches, the placenta also gets stretched. So this causes some small cuts here, what we call sharing of the placenta, which causes some bleeding. That is what causes antepartum hemorrhage. The sharing of the placenta caused by stretching of the lower uterine segment and the pressure from the fetus causes sharing of the placenta, causing bleeding, which is known as antepartum hemorrhage. So a normally situated placenta should be either anterior fundal or posterior fundal. A low-lying placenta is abnormal. Types of placenta previa. Placenta previa is divided into minor and major placenta previa. Here you have your type 1. This is the lower uterine segment. This is the internal os of the cervix. This is the external os of the cervix. Here you have your fundus of the uterus. This is the body. And here you have the placenta itself. In type 1 placenta previa, the placenta edge is in the lower uterine segment but does not reach the internal os. This is a minor placenta previa. In type 2, the placenta edge reaches the internal os here but does not cover it. Now, type 2A is an anteriorly situated placenta, the anterior aspect of the uterus. Type 2B is a posteriorly situated placenta, the posterior aspect of the uterus. Type 2B is a major placenta previa, whilst type 1 and type 2A are minor placenta previas. Type 3 placenta previa. This is when the placenta covers the internal os when it is closed, but not at full dilatation. Meaning that when the cervix is fully dilated, this is 10 centimeters dilatation, this is the cervix, the placenta does not cover it completely. Okay. In type 4 placenta previa, the placenta covers the internal os even when the cervix is 10 centimeters dilated. So the whole placenta covers the internal os even when the cervix is 10 centimeters dilated. Type 3 placenta previa and type 4 placenta previa are also major placenta previas. So type 1, type 2A are minor placenta previas. Type 2B, type 3 and type 4 are major placenta previas. So here I say type 1, it's also known as a lateral low-lying. The placenta edge is in the lower uterine segment but does not reach the internal os. It's a minor placenta previa. Type 2, also known as a marginal placenta previa. The placenta edge reaches the internal os but does not cover it. It's further divided into type 2A where the placenta is anterior. This is a minor placenta previa. Type 2A is a minor placenta previa. Type 2B, the placenta is posterior. This is a major placenta previa. And then you have type 3 placenta previa. This is an incomplete or partial central. This is where the placenta covers the internal os partially. It covers the internal os when it is closed but not at full dilatation. This is a major placenta previa. Type 4, this is also known as a central or complete placenta previa. This is a placenta which covers the internal os even at full dilatation and is centrally located. Etiology. The etiology is not known, but there's proposed theories like, let's say, they say the dropping down theory, where the fertilized ovum, the fertilized egg, gets implanted in the lower uterine segment. This occurs when there is poor decidual reaction. What do we mean by poor decidual reaction? Decidual simply means the modified endometrium. It's the modified endometrium in the pregnant state. It's simply the endometrium. Now, when we say decidual reaction, we mean the placenta getting attached to the decidual here. Okay. So what happens is that when there's a poor decidual reaction, the fertilized egg goes to look for an area where there's good endometrium to attach itself there. This occurs in cases like where there's a previous cesarean section or a previous scar in the uterus. So suppose that this patient had a previous cesarean section. The knife went through here, they cut through here. This forms scars later on, where in the next pregnancy, the fertilized egg cannot even implant here because it's not good endometrium, so it looks for other areas to implant. So it goes and implants itself in the lower uterine segment where there's good endometrium. The other theory is that you might have a big placenta, a big surface area of the placenta, like in multiple gestation, in let's say in twin pregnancy. So the placenta enlarges to accommodate for the twins. So it might carry on to look for space to attach into the lower uterine segment. Risk factors of placenta previa. You can have scars in the uterus, like I've just mentioned, poor decidual reaction due to a previous scar in the uterus. Like in previous cesarean section, previous myomectomy. Myomectomy is removal of the fibroids. Dilatation and curettage. This is commonly used where you're suspecting cancer of the uterus. So what happens is you dilate the cervix and you put a curette in here. You scrape off part of the endometrium and take the sample for histopathology. Now, the scraping of the endometrium results in fibrosis of the endometrium, which might result in scar formation. Asherman syndrome secondary to overzealous manual vacuum aspiration. So, let's say a patient had previous histories of incomplete abortions, and they tell you in the history that they cleaned them up. So that is a manual vacuum aspiration. So what happens is you put a cannula in here. Let's say there's retained products of conception. So there's a cannula connected to a syringe here where you aspirate these retained products of conception. Now the cannula might injure the endometrium if you're overdoing it, overzealous, okay? So this injury to the endometrium, when it is healing, it causes fibrosis, scar formation. That is what we call Asherman syndrome. Now, like I've said, the scarring in the uterus results in poor decidual reaction, meaning the placenta might not implant well where there's a previous scar. So it will look for another area where there's no scar, let's say, for instance, in the lower uterine segment, and implant there. That is what we mean by placenta previa. Why scars cause placenta previa. Okay. Endometritis. Endometritis is inflammation of the endometrium. This is caused by infections like sexually transmitted infections or introduction of infection during a manual vacuum aspiration. So what happens is there's inflammation of the endometrium, and once this resolves, there's healing by fibrosis, which results in scar tissue in the endometrium. Another one is a submucosal fibroid. In a submucosal fibroid, you find that there's a fibroid here, submucosal fibroid. The placenta won't come to attach here because there's a submucosal fibroid. This is what we call poor decidual reaction, okay? So it might go and implant in the lower uterine segment. Smoking causes placenta hypertrophy. This is because it compensates for hypoxia and carbon monoxide. So the placenta will enlarge, and might even encroach into the lower uterine segment. This is because it looks for nourishment. More risk factors like increased maternal age more than 35 years, multiparity, multiple gestation. Remember, I already mentioned about the big surface area of the placenta, and previous placenta previa. If a patient has had a previous placenta previa, it increases the risk to at least 4 to 8% in the next pregnancy. Clinical features. The only symptom the patient will present with you is vaginal bleeding. The vaginal bleeding is painless, sudden onset, recurrent, and usually spontaneous. And then when you examine this patient, the size of the uterus is the same as the gestation age. What do we mean by that? When you examine this patient and you say the height of fundus is estimated to be about 30 weeks, and according to her last menstrual period, she's about 30 weeks gestational age. This is what we mean by size of the uterus is the same as gestational age. And then the uterus is soft, relaxed, not tense. In placenta previa, the uterus is soft, relaxed, and not tense. Whilst in abruptio placenta, the uterus is tense. It's as if it's contracting all the time. The patient is usually hemodynamically stable. Hemodynamically stable meaning that the blood pressure is normal, the pulse is normal, the patient doesn't seem to be in shock, doesn't seem to be pale. Unless the patient bled a lot, then the patient will be in shock. And then you can have a high presenting part. What do we mean by that? Suppose when you examine the patient, let's say this is the uterus. Your placenta is low lying here. The head will be here. This is the head of the fetus, okay? So high presenting part, meaning that the head of the fetus, the presenting part, cannot fully engage into the pelvis because the placenta is preventing it from. So that is why you say a high presenting part. Instead of the fetus's head being here, instead it's high up here. Okay. Fetal malpresentation. The fetus might be in breech, transverse, or oblique lie. So in breech is where you have your buttocks here. The head is up there. Okay. Whilst in transverse lie is where you have a head here. The buttocks are either here or this side, and the legs are this side. Okay. Oblique lie is where you have the head is somewhere here. The rest of the body is going like this. This is common in placenta previa because the placenta usually, it's like it disturbs everything here. Instead of the fetus being well applied to the pelvis, it's either in breech or in transverse. Now, there's usually a normal fetal heart rate unless there's been a major bleeding which compromises the fetal heart. So unless the patient bled a lot or is in shock, it might compromise the fetus. Otherwise, there's a normal fetal heart rate. And then during your examination, do not do a vaginal examination. A vaginal examination is contraindicated. Imagine you put your fingers up there and you start poking the placenta. You cause severe bleeding, or you just disturb the placenta itself and cause severe bleeding. Confirming the diagnosis of placenta previa, history of painless and recurrent vaginal bleeding is very important. It's a clinical diagnosis. You order an ultrasound. Ideally, a transvaginal ultrasound is better than a transabdominal ultrasound because it's more accurate and more sensitive. So if you order an ultrasound, it might show you a low-lying placenta. Where you're not satisfied with the ultrasound results or imaging results, you can do an examination in theater. Examination in theater, make sure you've collected full blood count for this patient, you've grouped and cross-matched this patient, you've put up an IV access, a cannula, a too large bore cannula, the biggest cannula you have. So examination in theater is where you want to do a sterile speculum examination. Sterile speculum examination because you want to rule out also local causes. Local causes like a cervical polyp, CS cervix, cancer of the cervix, okay, and other like. So where you've ruled out these local causes, you can do a gentle vaginal examination. A gentle vaginal examination to see which type of placenta previa you are dealing with. Is it a minor placenta previa or a major placenta previa? So ideally, this examination should be done in theater, where you should be ready for anything. In case your vaginal examination triggers heavy vaginal bleeding, you are ready to do a cesarean section. The differential diagnosis of placenta previa is the other causes of antepartum hemorrhage, like we discussed previously. But specifically, it's important to rule out abruptio placenta because this is major life-threatening. Okay. Complications of placenta previa. The maternal complications are divided into antepartum, intrapartum, and postpartum. The antepartum complications, this is during pregnancy. There is malpresentation. Malpresentation like breech, transverse or oblique lie. Premature labor, which is either spontaneous or induced. Intrapartum, this is during labor. There can be cord prolapse. This is because there's abnormal attachment of the cord to the placenta. And then slow cervical dilatation. Slow cervical dilatation is because of the placenta is attached on the lower segment, which causes slow cervical dilatation. Then you can have premature rupture of membranes, preterm premature rupture of membranes. Then you can also get intrapartum hemorrhage. Intrapartum hemorrhage is because there's further separation of the placenta as the cervix dilates. Then there is increased risk of operative interference due to the complications of labor. Retained placenta. This is an abnormally attached placenta. Placenta won't come out on its own. You have to manually remove it. This is caused by a morbid adherent placenta. This is basically an abnormally attached placenta to the uterine wall. It is seen in placenta accreta. Placenta accreta occurs most commonly in patients who've had a previous seizure, and the risk increases in patients who've had 2 or more previous seizures. So what happens is this is your myometrium, this is the endometrium. Okay. So your placenta is attached here. And in this situation, the placenta is abnormally attached to the endometrium, and in some cases, it might even go as far as being attached in the myometrium. Now, this placenta is difficult to remove. You have to manually remove it. It's common in patients who've had a previous cesarean section or 2 or more previous cesarean sections. The other cause of a retained placenta is a big surface area of the placenta. So if a placenta has attached all the way here, a portion of it might remain in the uterus. Postpartum hemorrhage can occur due to a morbid placenta, like I have said. Morbid placenta, remember, as long as the placenta is attached to the uterine wall, the uterus won't contract, so the patient will continue bleeding, which can result into a postpartum hemorrhage. The other reason is because of anemia. One thing I forgot to mention is that patients with placenta previa can also present with anemia because of ongoing blood losses due to vaginal bleeding. Now, anemia causes atonic uterus, meaning the uterus does not contract well. The other reason can be because of failure of the lower uterine segment to contract because the placenta was attached there. So retraction of the lower uterine segment fails. And then in some cases where we have a big surface area of the placenta, it can cause an atonic uterus, meaning the uterus can fail to contract. So as long as the uterus is failing to contract, it can result into postpartum hemorrhage. Disseminated intravascular coagulation can occur in patients who you can't control bleeding, let's say in an atonic uterus, a retained placenta, even in postpartum hemorrhage caused by the causes we've already mentioned. What happens is where there's uncontrolled bleeding, the coagulation system gets activated. That's how you end up with disseminated intravascular coagulation. Postpartum complications, sepsis. Sepsis because the placenta is attached in the lower uterine segment. Then the lower uterine segment is close to the vagina. So there's an increased risk of ascension of infection. The other reason is in patients who are anemic, they are prone to infections postpartum, in the postpartum period. Subinvolution, this is because of a slow contracting uterus. They can also get an embolism, commonly amniotic fluid embolism. Fetal complications of placenta previa, they can have low birth weight. The low birth weight can be due to preterm labor, or the small amounts of blood loss per vaginal bleeding can result in chronic placental insufficiency, which can also result into intrauterine growth retardation. And then you can have asphyxia. Asphyxia can be due to early separation of the placenta, compression of the placenta, or compression of the cord. Intrauterine fetal demise can be due to, in cases where there's a heavy vaginal bleeding, where there's maternal shock, it can result into intrauterine fetal death. You can have birth injury. This is due to increased operative interference. And then congenital abnormalities. Congenital abnormalities are increased 3 times more common in placenta previa, especially neurotubal defects. So placenta previa in overall causes increased maternal and increased fetal morbidity and mortality. Management of placenta previa. A patient comes to you with vaginal bleeding and you're suspecting placenta previa. Do an immediate assessment. Approximate the amount of blood loss. Check if the patient is in shock. You check the blood pressure, the pulse, check if they are pale or not, the capillary refill time. Do an agent full blood count. Group and cross-match 3 units of whole blood and 4 units of fresh frozen plasma. Put up a large IV access. Do a gentle abdominal palpation. Do a vulvar inspection if there's active vaginal bleeding. Remember, vaginal examination is contraindicated at this stage. Confirm your diagnosis by taking the patient for ultrasound. Now, delivery depends on the gestational age, severity of blood loss, type of placenta previa, and the maternal and fetal status. Conservative management. This is where you wait and see. This is where you want to give the fetus more time to fully develop. You do this if there's minimal or moderate vaginal bleeding and in preterm, and where bleeding has stopped. So you admit the patient to antenatal ward, put them on bed rest, keep them cross-matched and IV access all the time. Do an obstetric ultrasound every 2 to 3 weeks for fetal monitoring. And also maternal monitoring like change of pads, routine full blood counts every now and again. And then if they're 26 to 34 weeks gestational age, give them steroids. Steroids, remember we've said dexamethasone 6 milligrams twice a day, at least 4 doses. And then you put the patient on hematinics. Hematinics is ferrous sulfate and folic acid. Now, if they have a low hemoglobin level, you can also transfuse them. The aim is to deliver the patient at 37 weeks gestational age. Okay. Vaginal delivery can only be attempted if the placenta age is clearly 2 to 3 centimeters away from the internal os and is anterior. For example, a minor placenta previa. In this case, you can do an induction of labor where you do rupture of membranes and put them on oxytocin infusion. Now, if the placenta edge is within 2 centimeters from the internal os, that's just too close from the internal os, or any placenta that is in the posterior aspect, or any thick placenta, or a major placenta previa, do a cesarean section. Active management of placenta previa. This is where you deliver regardless of the situation. So in cases where bleeding is continuing and of moderate degree, do a cesarean section. If the bleeding occurs at term, do a cesarean section. Patient comes to you in labor and is bleeding, do a cesarean section. Patient is not hemodynamically stable on admission, do a cesarean section. Where there's heavy bleeding, do a cesarean section regardless of the gestational age, even if the baby is premature. Where there is fetal distress, do a cesarean section, and where you suspect congenital anomalies like neurotriple defects, do a cesarean section. Where there is intrauterine fetal demise, you can do vaginal delivery if it's a minor placenta previa and if the placenta age is 2 to 3 centimeters away from the internal os. Otherwise, do a cesarean section. This is the end of our discussion on placenta previa. In the next video, I'm going to talk about abruptio placenta. But before I talk about abruptio placenta, I'm going to try to squeeze in vasa previa and morbid placenta. Thank you for joining me. We'll see you next time on this channel. Please don't forget to subscribe for more videos. Thank you.